what's cool is a raphe is essentially a seam. So where just like layers are folding in on each other and meeting.
So why don't they call it a seam?
Connective tissue seam. But it's if you look, it's a junction where many layers meet, okay? And it's here more posterior than anterior, even lateral, transverse abdominis and both obliques. So your 3 of your 4 abdominal muscles, 3 abdominal muscles come all the way around and meet right there. The lumbar dorsal fascia or the thoracolumbar fascia, those are synonyms for each other. I tend to say lumbar dorsal, but thoracolumbar is probably more, bless you. But thoracolumbar fascia is a bit more common. That's that big connective tissue white triangle on the low back, right? And it attaches to latissimus dorsi, it feeds into the glutes, gluteus maximus. But then we run deeper here, and then we're to quadratus lumborum, and even psoas.
As soon as you said it, I was reading the word as you said quadratus lumborum. I was reading it.
Many times people will, they'll shorten it to an acronym. So that one we'll call it QL. You hear QL as short lingo all the time. Very rarely, once you're out in a professional setting, are people going to say quadratus lumborum, they're going to say QL. If you look up video references and everything, it's going to be QL release, all of that. Sternocleidomastoid, same kind of thing. That's this one. SCM. But QL, it usually, if you see anybody showing this application, it's going to be that they're saying they're doing a QL release, a quadratus lumborum release. The truth is, and this is revisiting a little bit what we talked about 3 weeks ago, is that in many cases the pressure depth is not enough to be all the way to quadratus lumborum. Quadratus lumborum is very, very deep. It attaches onto the iliac crest and comes up on the lumbar spine and floating the last rib. So it's even involved with like breathing stuff. Important thing, an important angle, all of that. But just remembering that working here, starting very lateral, trying to be a bit more anterior. So I'm trying to come just straight down and maybe even push a little bit towards the anterior side. With that directional force, I'm going to be predominantly, ideally on quadratus lumborum and along with the obliques. But since I'm distorting quadratus lumborum, I will be affecting secondarily psoas. So you can affect psoas by doing this application. If anybody remembers, the pressure. So just real tiny action. All she has to do is start to lift her bottom leg up off the table. Real tiny, hold. And then very slowly back down. So that's the contract, relax piece of this. The combined actions would be, okay, lift your leg a little bit. Okay, hold, big deep breath in. And then all the way out, nice and easy. Perfect. Now we're on the unaffected side. Usually I just pay attention to what I'm feeling, but starting out, you're gonna want to draw the client's attention to how all these, draw the client's attention to how all this feels. Now you're pushing pretty deep. Many of these areas are gonna be sensitive, right? There's gonna be spots here that feel like something. But it doesn't necessarily mean that they're part of a bad symptomatic like chain of like a guarding pattern or compensation pattern. It's just some areas, when we get to the hip, for example, you push into gluteus medius, gluteus minimus, it'll always be sensitive. There'll be tender points always in those areas. doing this mostly just because I know that through assessment, and it was a pretty small assessment, but the action that she had shown us was related to frontal plane movement. That means it has to be the lateral flexion, abduction, adduction. And then there was, when we were talking further, she had mentioned something about like even the rib, the lower rib feeling like something, and it's like, well, it has to be that then. And it's nice because then I can confirm, like it has to be QL. I'm just working my way. But if that is affected, if Quadratus lumborum has increased in tone to the point that it's limiting the mobility of the whole lateral raphe, then it means that all of these structures are going to start to become more toned, more fibrotic, and usually by the time somebody gets to you, what you're stuck having to do is free up the whole thing, not work on just one individual muscle. And when this area is pretty symptomatic, rarely am I actually able to apply a lot of pressure. And it starts with me probably doing a release more of the superficial layer of the lateral raphe, which would mean I'm pretty much just working on where the obliques interface with the thoracolumbar fascia. And once that's freed up, then we can start working deeper. This is just really a practical thing. You're going to have to think more in terms of the muscles and really knowing Quadratus lumborum and everything. But from a practical perspective, a lateral raphe is a way more useful idea in relation to just figuring out how to help somebody, because it gives you a bigger arena related to many muscles as opposed to worrying about any individual one. And just where do you work along that seam? Where do you make the whole thing as pliable as possible in order to get the effect you're looking for? So there's a little bit of shoulder stuff, neck stuff. Remember, you can use soft fist and everything, even here. Works really good, doesn't have to be palm. Now just to balance, we're gonna be looking at sideline in our other demo more. Okay, lift your leg up. Okay, nice and easy. Very well.
When the part of putting the pressure on the muscle and having the person move the leg in this case, that is active muscle energy, right?
Yes. Yep. You can basically say that anytime you are applying inhibitory pressure, and really muscle energy techniques could be further simplified to anything that incorporates active movement through direction to the patient or the client. So I say, all right, you're having elbow issues, elbow pain, elbow mobility problems, and then I coach you through do this and do this. The active movement piece is the biggest part of muscle energy. Usually what has to be incorporated is pushing through resistance. So physical therapists, physiotherapists, chiropractors, other manual therapists may not incorporate osteopaths. They may not incorporate the inhibitory pressure plus the movement. Like I'm always gonna say, why wouldn't you? But they're gonna say, okay, we have an elbow movement related issue. I'm gonna have you do elbow flexion, elbow extension. We're gonna have you do it through resistance. That could be done with bands or weight machines, or usually in a therapy setting, it's just the practitioner applying the force and saying, okay, push against me, keep coming, okay, push against me, keep coming. But all we're coaching is active movement in 2 planes. And it could be just one. It could be push, okay, let go. Push, let go. That is contract, relax. Then I could do, okay, let go, other way, contract, relax, antagonist, contract. That is it. Then we just add on the inhibitory pressure. And so the way you're going to learn it is inhibitory pressure plus movement. And then there's just a name for everything related to just what movement you pick. So this one is the easiest because it, and this is just revisiting a little bit, but the lateral flexors and abductors co-contract with the opposite side adductors. It's a whole balancing thing. When I do this action, my pelvis is doing this, and the adductors are shortening, and all of this is shortening. So short, short. Yeah. Short, short. And part of what I want you to always remember is that with low back issues, we talked about the importance of working everything around the pelvis, but also the main upper leg attachments. So it's usually going to be related to sagittal plane movement stuff. Like I have something that hurts right here, and the difficulty of movement is standing up on this person, or I'm stuck like this. I can't bend forward. Sagittal plane movements, erector spinae, psoas, usually the bigger culprits. The leg muscles that would be a part of that would be proximal hamstrings and hip flexors. So both, again, sagittal plane movers, but we're just going down the chain and finding what would be synergists or antagonists related to that. Frontal plane, frontal plane, I'm on the lateral flexors, and I'm thinking about abductors and adductors. And just making sure we get to those structures is the best tactic. Now in prone, we actually already worked on adductors for her. And that wouldn't be my preferred way of doing it, but that's how we had set that up. Now we're gonna just balance this one out. I think I feel a little bit more, but I shouldn't. I usually would tell you, try not to give people false positives like that. Like, do you feel that? I feel that. You're already kind of, what's the word? It's false positives, ultimately, is the term I'm thinking of. But you can. Yes. All right.
That was on the tip of my
Thank
tongue.
you. That was good. So if you say, "Oh, I feel something," do you feel that too? Then you're being overly persuasive, and you're going to basically get them to immediately tend to agree and not give as much of an honest assessment.
Yeah. So
Influencing it. Thus, I would prefer usually, this is how I say, I keep it pretty vague. I go, does that feel like something? Does that feel like something similar to your symptom? Something like that. Or I can be even more vague and say, as I work through here, please tell me when we find something that feels like it's part of the symptom, or something that really jumps out at you. And it should have that kind of good hurt quality, or just feel like it's that productive intensity, never just pain for the sake of pain. Okay.
So you want to not influence her answer.
Yes. I want as much of an honest response as possible. So through here. How does that compare to the other side? Yes. So the phrase was, it feels much more like a release. You're okay. You can go past that. I'll edit you out. Don't worry. We were. And I got that. I said, how does this compare to the other side? Because I had preemptively told her, like, we're going to work here, and I want us to be sure that we're comparing it to the symptomatic side. And then she said, this feels like more of a release. That's a pretty good way of phrasing it, if you think about it, right? All right. A little lift of that bottom leg for me. Real tiny. That should make it feel less. Good. Real slow back down. Exactly what I talked about with working on the shoulder, using elbow movement and then rotating the shoulder. This is such an easy action. Okay, again, lift. That's perfect. Big deep breath. slowly back down. Okay, little lift and breath. And down. That was a deeper breath. A better exhale. How does that feel from where we started? And then that's correlating with what felt to me like we started here and then suddenly we were here. Like in this case, got significantly softer. And then I just shift. So starting here, I was real lateral, so sometimes I gotta be right here. If I sometimes would have to get on a step or use the hydraulic table, come more straight down. That's to be sure we're affecting the obliques, quadratus, lumborum, psoas. Then I just have to come further back, more posterior, increase my elbow angle, and then I'm on the other stuff, which can be more erector spinae, thoracolumbar fascia, all that. So, work. All right. Elbow slide. Bring it up just a touch.
My knee?
Yes.
Oh.
Yes. Okay. Sometimes when they're slide, if they get that kind of slide, before I had just the bolster on the table and that was slipping. Sometimes their leg slips. As long as they're comfortable, get that elbow, get their hip angle to be a bit more inflection. Hip angle, good. Put their hip more inflection. They just add words. All right. There, you should feel more safe.
Yeah.
A little slip.
It's just,
Don't worry.
It's
about
hard
it.
not to like hold.
Yeah. Now, how does that compare?
Like I need to breathe.
Oh, not too much?
Nope.
Okay. But it's just something jumping out at you?
Yeah.
Is that part of the symptom?
Mhm.
Okay. Well, you heard all that, confirming not a bad hurt. It feels like it's part of the thing, right? Okay. So real tiny, just real small lift. Doesn't have to be big. Get a tiny, tiny, tiny. Back down. It can be even smaller than that. Just real small. Lift right there. And then big breath. For as big a breath as really feels comfortable. Slow down. Excellent. That was perfect. Yep. Breath. Once they know what to do, so I don't have to keep on telling her. She can just kind of listen to her own body and find that. It should innately feel really good to do. Like I just have to wait. One more. Hold it a little bit longer. Let's do a couple breaths and keep moving. Do 2 breaths. One more. Hold your breath a few seconds. And then out. Perfect. As a touch of a nuance, but using the hold of a breath at the peak of inhalation is similar to by increasing the activation in a muscle energy technique. It is a muscle energy technique. If you think about like when people do weightlifting, how they hold their breath. So holding the breath causes body-wide muscle contraction. So with respiratory related muscles, you can create a little bit of an added effect related to shortening concentric actions by having them hold their breath just for a couple of seconds, not for like hold it for 30. 5 minutes. Wow. Moving more and more posterior, and here's the secret sauce of being able to be real thorough in each one of these spots, because I moved maybe a half an inch, and suddenly I'm on something completely different. And what I'm ideally looking for, now I can feel stuff, but what I would need from her when I was starting out is an indication. Is it more there or more there? Thankfully that cues up what I felt. And if it wasn't, I wouldn't have admitted it. I wouldn't have admitted it. All right, tiny lift. Yeah, perfect. Breath, excellent. And usually once you get a couple of these parts of the structure mobilized, then everything else starts releasing or freeing up more quickly. There. You're already moving. Now for you, how is this here? This one?
It's okay.
Yeah, that feels all fine. So it's confirming for them too, where is it? Because when you're symptomatic, this stuff can refer. And once one part of the structure is tight, it may really be causing, like if this gets real tight over here, it might be causing strain. What feels more like your SI joint. You keep on trying to work on that part of it and stretch here, when the causal element may be far more lateral. And you just don't feel this symptomatically because it's deep. So suddenly you free that up, and so what I was able to confirm through palpation and through the client's impression related to the pressure was that the symptoms are related to these lateral flexor, more laterally sourced muscles, so call it Quadratus lumborum, and not as much about the erector spinae. And that's an important piece for both of us to be aware of, right?